You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract. Welcome to another episode of Beyond the Abstract. In today's episode, we're talking to Dr. Joji Suzuki about a recent article he co-authored in the Journal of Addiction Medicine entitled The Efficacy of GLP-1 Agonists in Treating Substance Use Disorder in Patients, a Scoping Review. Dr. Suzuki shares why he feels GLP-1 agonists could be a promising tool in the treatment of substance use disorder, and also talks about the future of GLP-1 agonists in terms of potential studies and implementations. Dr. Joji Suzuki is the founding director of the Division of Addiction Psychiatry in the Department of Psychiatry, Brigham and Women's Hospital, and an Associate Professor of Psychiatry at Harvard Medical School. He is board certified in both addiction psychiatry and addiction medicine, and has continued to maintain his clinical role as an inpatient addiction consultant at Brigham and Women's Hospital. Over the course of his career, he has successfully launched numerous treatment programs, including a comprehensive outpatient dual diagnosis addiction clinic at Brigham and Women's Faulkner Hospital, and a low barrier, low threshold harm reduction bridge clinic at Brigham and Women's Hospital. He has received NIH funding continuously since 2017, having completed a K23 Career Development Award to receive training in conducting clinical trials with an emphasis on research to improve the care of hospitalized patients. He's now a principal investigator on multiple NIH-funded trials to evaluate novel pharmacologic and psychosocial treatments for substance use disorders. Now let's get into today's talk with Dr. Joji Suzuki. So I'm going to let you take it away. We traditionally start with asking our guests a bit about why in the world this field, like of all the specialties that you could have, the roads you could have gone down, the specialties that you could have sort of pursued, what was it that got you interested in the field of addiction medicine, and what have your experiences been like over the course of your career up to this point in this field?
Yeah, for sure. So it starts back in terms of, my interest in addiction goes back to my time as an undergrad as a chemistry major, actually. And so that's when I got interested in sort of chemicals, and I remember vividly going to the Museum of Science and seeing this display about how certain chemicals impact your brain in certain ways. And it was talking about neurotransmitters and also using things like, heroin, cocaine, and how they attach to similar receptors and cause certain psychoactive, effects. And that was so fascinating to me in terms of as a chemistry major, sort of making that link between certain chemicals and how it affects your body was really fascinating to me. But after college, actually, what I pursued first is actually to be a research assistant in a clinic that treated psychological trauma. That was my foray into medicine and psychiatry, and the researcher, psychiatrist that I worked for really inspired me to think about, pursuing psychiatry as a field. So my initial interest in medicine was through psychiatry and psychological trauma. But during medical school, I learned that there's a, strong connection between trauma and addiction, and really started getting more interested in addiction treatment. And I had some really phenomenal mentors in Boston who really encouraged me to consider, including addiction as part of my overall career. And during residency, it was really heartbreaking to see the evolution of the opioid crisis. That's when the opioid crisis was starting to emerge. And that's when I really learned that, I really want to understand how I can be a part of in treating substance use disorders. And so I decided to pursue addiction psychiatry fellowship training back in Boston. And that's when I learned about hospital-based addiction consults. And that's when I fell in love with that kind of a work where I can really be in the middle of a hospital setting, helping my colleagues, in addition to patients, in addressing their underlying substance use. And that's been one of the consistent themes throughout my entire career, is that patients with substance use disorders, we know, don't get a lot of treatments and cannot easily access treatment in general medical settings. The typical primary care clinic office or the emergency room in the hospitals. But the reality is patients with substance use are disproportionately represented in those settings, right? And so there's just sort of, weird discordance between the fact that patients with substance use present and are overrepresented in these settings, but we're not formally taught on how to address it and treat it. And so being a hospital-based consultant really made me feel like I could be valuable. I'm one of the few addiction specialists who can really provide help, not just to the patients, but to my colleagues. And I really also believe that a hospital consultant can contribute to changing the culture. And what I mean by that is, hospitals and emergency rooms are staffed disproportionately by junior trainees, right? Third-year medical students, interns, they spend a ton of time in the hospitals. And so I think it's important for people like us to be in the middle of that and to really reinforce the idea that treating substance use is like any other medical care. You would address the cardiac issues in the hospital and the renal issues and endocrinology. You would call all kinds of consults. And historically, the substance use disorder issues would be relegated to somebody else at some other time, not in the hospital. And by having us there really reinforces the idea that it's our responsibility and it's part of medical care to treat the underlying substance use, which are often the major contributing driver to their presentation in the first place. So, that's really been my, experience throughout. And so, I finished medical school in 2002 and residency in 2006. So I've been able to sort of witness the entire arc of the opioid crisis in a way. So as a medical student, I had a hand in overprescribing Percocets and oxycodone after surgery. And, I personally had a hand in that. But I also have been able to witness the arc of buprenorphine treatment, for example, which became available in 2002. And so I've had this interesting, perspective of seeing the opioid crisis as it emerged and how our response has evolved over that time. And I really strongly feel that, hospital-based addiction work has really emerged out of that as a very important niche within addiction treatment. And I think it's just great work, and I still do it to this day, and I enjoy it quite a bit.
Amazing. Well, we're going to talk a little bit about your review here in a minute, but I want to start first with GLP-1 agonists. Tell me a little bit about why are these GLP-1 agonists considered such promising tools when it comes to treatment for substance use disorder?
It's a great question, and GLP-1s definitely are the hot, item today in medicine, and for good reason, because I think another thing that really drives me towards this work that I do and the research is that after 2 decades of the opioid crisis and the evolving drug crisis, we actually don't have a whole lot of innovative approaches to offer our patients. And we are long overdue for more, better treatments, additional treatment options we can offer. And GLP-1s represent one of those. I think there are many potential, new therapies emerging, but GLP-1s definitely is one of them. And partly driven by, and surprisingly, not necessarily by randomized trials. And we can talk about those, but it's really driven by a pretty large chorus of individuals who take GLP-1s for diabetes or obesity, who are spontaneously reporting that it's led to a reduction in drinking, or reduced smoking or other drug use. And, I hear this all the time from our primary care colleagues who prescribe a lot of GLP-1s, and they've had plenty of patients who just spontaneously report, "Oh, doc, I stopped drinking," or "I cut back, and I'm not even trying." And we never generally hear that. Like, that's not something we get from our patients much. So it's led to us really paying attention. And so there's at least a half dozen trials now currently underway to test specifically semaglutide for alcohol use disorder, and a couple for tobacco and a few for opioid use disorder. And in fact, we are currently preparing. We just got funded by the NIH to conduct a pilot randomized trial of semaglutide to target opioid use disorder. So it's exciting because it's a potential new treatment option, But I would say that the randomized trial data is actually not that strong. It's promising, but a lot more research is really needed.
Interesting. So now for the clinicians that are hearing this and maybe their ears are perking up going, oh, there might be something there. What factors do you think that these clinicians should consider in this potential implementation if they're looking to put GLP-1 agonists into their SUD treatment?
So for right now, I do not believe it's ready for prime time. And so if the patient is receiving GLP-1s for treatment of diabetes or obesity, so those are the clear FDA-approved indications of these medications, and they also happen to have a comorbid substance use, of course, and it's very reasonable to do, prescribe these medications. But in the absence of those, medical comorbidities, obesity and diabetes, I'm not ready to, make recommendations that we should be, actively prescribing them for substance use disorder treatment. Now, patients may still ask for it, and I think it may be a reasonable thing to consider. But I would just exercise caution. And there are a couple of issues. Number one is, of course, the availability and the supply issues have been fairly persistent. And if it's being prescribed for non-approved indications, then the insurance companies may not pay for it, right? So the coverage issues are pretty significant. And so, I'm always wary of recommending new therapies where we may actually inadvertently worsen disparities. It's not really helpful if this is only available to those who can afford it, and that's really not fair at all. And so, but beyond that, I think there's still questions that remain about, is it safe to administer GLP-1 to those who don't have diabetes or obesity? So most of the trials have excluded those who are, BMI, for example, less than 25 are excluded. And so there are total of 4 randomized trials. There's 4 randomized trials, 3 for exenatide and 1 for duraglutide. These are all older medications. Exenatide was the first GLP-1s that came out 20 years ago. And duraglutide, maybe another 5 years after that. And these are older GLP-1 compounds that are quite different from the current versions, like semaglutide or tirzepatide, which have a much higher efficacy, likely due to the greater homology with native GLP-1s. And because of that, they seem to cause significantly less side effects. But in the older studies with exenatide and duraglutide, the ones that were positive, where the signal was strongest, was when these medications are given to those who are overweight.
Interesting. Now, you just mentioned, you mentioned a little bit about the comorbid disorders, and I know your review found positive effects of GLP-1 agonists on decreasing tobacco and alcohol use, specifically in individuals with pre-existing metabolic disorders. So talk to me a little bit about what role do you feel that GLP-1 agonists can play in treating patients with comorbid disorders like co-occurring metabolic disorders and SUD?
Yeah, I think in that situation, it's potentially really nice, intervention to target both the metabolic, issues, the diabetes, the obesity, and the underlying substance use. And predominantly what we have the signal for now is alcohol and tobacco, which are, of course, highly comorbid with, diabetes, et cetera. And so I think there are many patients who likely benefit, both in terms of, blood sugar control, weight loss, and helping to reduce, alcohol and tobacco. Again, what we reinforce is that the data that we're basing it on is from the older versions. And so if anything, the newer versions may be more efficacious and less, likely to cause side effects, but we're still waiting on the actual, trial data. What we also have currently are population level signals of the correlation between the use of GLP-1s, specifically semaglutide, but other GLP-1s as well, on things like cannabis, cocaine, alcohol, and now another one just came out this past week, looking at the population level, semaglutide and opioid-related overdoses. All of the population level studies showing a correlation in the right direction. The use of semaglutide or other GLP-1s lead to less cocaine use, less alcohol, less opioid overdoses, and also confirming that it does not seem to worsen mood or suicidal ideation or behavior. But that was one of the concerns that came up: is does this lead to worsening mood and or worsening suicidal ideation, behavior, etc. But the most recent review really points to that, if anything, it's going to reduce suicidal ideation and behaviors. But more research is clearly needed. But everything is kind of in the right direction, so to speak.
Well, and you're kind of speaking on the future and what can come down the line. So let me ask you a bit about that. You're talking about some of the new research, some of the things that are being found now. What future research questions do you feel kind of emerged from your review, and what would you like to see in terms of what kind of studies do you think would be able to address some of these questions or address some of the concerns that you feel at the moment still exist?
Yeah, so there are a ton of questions that remain unanswered. And one of the most urgent one that we need to answer is whether the newer GLP-1s like semaglutide or tirzepatide have the similar efficacy around reduction in substance use for alcohol or tobacco. Again, the ones that we have so far are from the older versions of the exenatide, which is literally the first GLP-1 that came out 20 years ago. So I think it's going to be important to replicate those studies using the newer version. So that's one. Number two is, just like in the context of weight loss, just taking the med and not doing anything else may not be the best way to approach, addiction treatment. It's hard to know. We just don't know. To what extent do we need to include any type of psychosocial intervention? Do we need to pair that with existing therapies? So, for example, in the trial that we're going to be doing of semaglutide for opioid disorder, we would not recommend this as a standalone monotherapy. We would do it as an adjunct to buprenorphine, for example. And so similar types of questions will come up. The tobacco trials actually that I've been referencing, they were all conducted in conjunction with either nicotine replacement or varenicline. So it was not given as a standalone monotherapy. And in fact, everybody in these trials also get behavioral therapy and counseling. So it's always in conjunction. And I would maintain that still remains probably the best default position. It may turn out like we've now learned from buprenorphine, where the concurrent, psychotherapy, it's unclear what role it should or should not play. But that question remains still open. And so I would not assume that you can just give the injection once a week and you're done with it. I think for many patients, they're going to require additional support. And, with the evidence around weight loss, it's not clear exactly, but, as soon as people stop taking the GLP-1s, their weight comes back. Right. And so a similar kind of a concern would exist with substance use. If you stop taking, or can you extend the benefits by encouraging more, lifestyle changes and relapse prevention strategies and the counseling and the psychotherapy? So all of those things remain unanswered. We don't know, and the appropriate dose should the dosing be targeting dose ranges for diabetes versus weight loss? The weight loss doses tend to be higher, for example. Do we need to know? And what is the actual mechanism? That part still remains unanswered. We assume it has something to do with the GLP, receptors in the brain. So we didn't talk about this before, but basically in response to food consumption, GLP is released out of the gut, but also the brain. And in normal circumstances, the GLP-1 is degraded very rapidly. So we don't think that its effects on the brain is that substantial under normal physiologic conditions. But with the exogenous, when GLP-1 medications are given, the whole point is that they persist much, much longer. And and so they're targeting likely the brain receptors, and GLP-1s are highly expressed in the mesolimbic reward pathways, for example. And so we don't know the exact mechanism still. Another thing that's emerging with GLP-1s is that because of the supply issues and potential disruptions in the prescriptions, people are already talking about how to extend it, like give lower doses, or they're even calling it microdosing of GLP-1s. So as you know, there's microdosing of psychedelics, there's the microdose low-dose buprenorphine, and now there's microdosing of GLP-1s. And some people think that actually there's something to it. So that's yet another sort of way that these medications could potentially be utilized, which we virtually have no empirical data on.
Well, Dr. Suzuki, I'm going to shift gears just a little bit. Our tradition when we end the show here is we always like to pick our guest's brain for a little bit of advice. And we've heard where you started your career and how you ended up, and you started with chemistry, and look where we are now. So I would love to know, what advice would you give not only to your younger self, maybe early in your medical career, but what advice would you impart onto the next generation, the up and coming generation of the addiction medicine professionals listening today?
Yeah, that's a great question. And so I think there are a couple of things. Number one is that to really embrace the interdisciplinary approach early on. And I was lucky that I ended up in the inpatient consult service because that's part of the larger psychiatry consultation service. And, in CL, as we call it, we live at the intersection of psychiatry and other departments. So that's been that's really ingrained in the way we think in terms of, collaborating closely with our medical, surgical, emergency, hospital, primary care colleagues. But I didn't really appreciate the value of that until much later. Like I took it for granted, and when I look around, I definitely see, the younger generation where they're not necessarily steeped in the CL world, where you end up getting a silo. This is a common theme that emerges in academic, medicine and hospitals, that we are so siloed by departments for a number of reasons. But I really, think that, having reached out to my medical and other colleagues has really made a big difference in terms of, what work we can get done. And when it comes to substance use, it is not. It is multidisciplinary, interdisciplinary. We need all hands on deck. And so, from early on, really reaching out and working with your psychiatric and medical and surgical colleagues, they need help as well. And so, doing that early, I think it's important. Another one is there's a tension that exists with harm reduction and the traditional addiction model. And that was still an issue when I was a medical student 20-something years ago. And it still remains as controversial distinction, which I think is so unnecessary. Because harm reduction as a principle is something we adopt and embrace in medical care all the time. And we don't call it harm reduction. It's only called harm reduction when it comes to substance use. And so maybe that's just, a fact that so much of the traditional addiction treatment has been sort of abstinence-based model that persists. But abstinence is a perfectly reasonable goal within the harm reduction umbrella. And so I wish we can, I think that newer generations hopefully can sort of abandon this kind of baggage that we've, put it on, and really embrace the full spectrum of approaches and really embrace all pathways to recovery, which is what our patients are telling us. There's no one right way to do it. And there are many appropriate ways to get to, up this, this journey called recovery. And we should embrace it all. And harm reduction is part of that. Abstinence is part of that. And so I want the younger generations to really, discard this old baggage, this tension between harm reduction and abstinence. And then I guess the other is to be open to, new therapies. That we are actually in desperate need of better and more options to offer our patients. OUD treatment is a good example. If somebody is failing buprenorphine, we got some other options, methadone, naltrexone, then refer to counseling and that sort of thing. But beyond that, there's not a whole lot more other than more buprenorphine, or injectable buprenorphine, buccal buprenorphine. I mean, it's all buprenorphine, so that's why the GLP-1s is so exciting in a way, because it's a completely different mechanism of action that may help support our patients along their journey. And this applies to other pharmacotherapies as well, but I think that's one of the reasons why we are excited is that this could, usher in a new approach to addiction treatment, which is completely different from existing approaches. It's not an opioid agonist or antagonist, right? So it's kind of cool that way.
Words of wisdom from Dr. Suzuki. Sir, thank you so much for sitting down and talking all things GLP-1 with me today. I feel like I got an education. Thank you.
Thank you so much. Appreciate you taking the time.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.